I have the pleasure to present Dr. Carol Shields. طبعا Carol Shields was she's the president of the Project Sepsis Latin America. She's a leader in the field of ophthalmic oncology, and she is a very reputable figure in the international arena dealing with tumor. Carol completed her fellowship training in ocular oncology and ophthalmic pathology at Wills Eye Hospital. And she is currently the director of the oncology service of Wills Eye Hospital at Thomas Jefferson University, where they manage hundreds and hundreds of patients with tumors. I was privileged to do a fellowship with her in 97, from 97 to 2000 to 99. And I have to tell you, she's a very hard worker. يعني. Carol, this is your first time to Egypt, and you cannot know how happy we are to have you. It's 5:30 in the morning, and besides this beautiful smile, the commitment, and we're extremely happy to have you. So we'll go with your presentation, and then we get questions for you, Carol. Nice having you in Egypt.
I have no financial interest or relationships to disclose, and I'd like to talk to you about adverse reaction, controversies in ophthalmology. And one controversy was chemotherapy for retinoblastoma. Does it even work? Now I'm talking about historical ocular oncology. From protest to success. Let me explain to you. Back when we started chemotherapy in the early 1990s, we heard various comments like, chemotherapy does not work for retinoblastoma. Why use it? Or don't touch vitreous seeds, that can seed the orbit. Or if you have vitreous seeds or aqueous seeds, you must do urgent enucleation. Chemotherapy will only be temporary. And one quote from a very prominent ophthalmologist was, chemotherapy will lead to tumor recurrence and possibly patient death. And that ophthalmologist even warned me that, Carol Shields, you could be killing children. I was nervous about this. Well, in the 1950s, yeah, chemotherapy did not work for retinoblastoma. Same in the 60s, the 70s, and the 80s. The regimens that we were using was not effective. But back in the 90s, the early 1990s, we found a regimen that worked. Credit to Dr. Judith Kingston at St. Bart's Hospital in London. She had a good idea. At St. Bart's, Judy Kingston, who had amazing dedication to her retinoblastoma patients, and she was working with John Hungerford, a consultant in retinoblastoma. And at this time, treatment of retinoblastoma was largely confined to surgical treatment like enucleation or radiotherapy, like external beam radiotherapy. And I practiced during this era. But Judy's knowledge and understanding of chemotherapy for children led to an important discovery. She applied a chemotherapy that she routinely used for neuroblastoma to retinoblastoma. Just 2 cycles, and it worked, 1994. And then later we modified it to 6 cycles, and it worked permanently in most kids. This was such an important discovery that in 2021, 27 years later, I wrote an editorial with Jerry Shields to the Asia Pacific Journal of Ophthalmology entitled, Here Comes the Sun for Retinoblastoma. In it, I indicated that Judith Kingston was a pioneer of chemotherapy for retinoblastoma, and may she never be forgotten for what she did for this field. And her collaborator, John Hungerford, a retinoblastoma expert, he credited Judy Kingston's contribution and said, this has been paramount to the current worldwide treatment of this tumor in thousands of children. Here comes the sun for retinoblastoma. Things totally changed from the 1990s to current. Chemotherapy for retinoblastoma revolutionized care. More lives and eyes saved than ever. Minimal toxicity, available in all continents. It's practical. I think it's the single most important discovery in the retinoblastoma world thus far. So we use chemotherapy in intravenous delivery for bilateral retinoblastoma and intraarterial delivery for unilateral retinoblastoma. We inject the vitreous for vitreous seeds and the aqueous for aqueous seeds. It's fairly non-toxic, no second cancers related to the chemotherapy, and it can reverse cancer. So if we look at a timeline, it was 1994 that intravenous chemotherapy was introduced. And then 4 reports came out in the journal Archives of Ophthalmology. One from Judy Kingston in London, Brenda Galley in Toronto, Carol Shields in Philadelphia, and Lynn Murphy in Los Angeles, with an editorial written entitled "A New Era for the Treatment of Retinoblastoma" by Rick Ferris and Emily Chu. We all outlined our success and failures with intravenous chemotherapy for retinoblastoma, but now we have 30 years follow-up. And I'd like to thank publicly Dan Albert, the editor of our Archives of Ophthalmology, in 1996, because he published these 4 articles and the editorial, this paradigm shift in the way we manage retinoblastoma. Of course, I submitted our work promptly, and Dan asked me to wait for the other 3 centers to submit their work. So I waited 1 full year with all that good data, and we published all 4 reports together in the same issue. It was an amazing issue, and it was an honor to be a part of this history and this momentous ophthalmologic issue. So the management of retinoblastoma has changed from enucleation, external beam radiation, and plaque radiotherapy to chemotherapy. So the current management is all about chemotherapy. Here's some of our results, 25 years follow-up, before and after intravenous chemotherapy with consolidation, another eye, before and after no consolidation, and another eye that showed the reality. Yes, you can get tumor regression, but it can become recurrent. And in those cases, you have to go on to either further intravenous, intraarterial chemotherapy, or plaque radiotherapy. And here's one case in 1994, just when we were starting intravenous chemotherapy. We had a bilateral group D retinoblastoma in a young girl from Florida. Total retinal detachment in both eyes. I did not know how this was going to turn out. And here she is, 30 years old. Her vision is now 20/30 in the right eye, 20/70 in the left eye, no metastatic disease, both eyes saved with decent vision. So let's fast forward to 20 years. Is there still good tumor control? Like, is this intravenous chemotherapy lasting forever? Well, we did this. We did a research protocol on long-term 20-year real-world outcomes of intravenous chemotherapy for retinoblastoma in almost 1,000 eyes of over 500 patients, published in the BJO 2020. And what did we find? Well, divided by groups A, B, C, D, and E, we found at 1 year, we had excellent control in A, B, C, and even D, and intermediate control for group E, 47% of globes saved, whereas A, B, and C had over 93% of globes saved. And that persisted in 2 years, 3 years, even at 5 years, 10 years, 20 years, even though we only gave 6 months of chemotherapy. This lasted with complete control up to 20 years. So basically what we saw at 2 to 3 years lasted for 10 to 20 years. So yes, in answer to that question, it is lasting at 20 years. But the caveat is you might need to be creative in your work because you might have to add on other treatments in case there is recurrence. For example, the need for intraarterial chemotherapy or plaque radiotherapy, IAC in blue, plaque in green. You can see that some patients will need these additional therapies. We usually start with IAC, and if that fails, go on to plaque. So overall, about 17 to 19% of children who get intravenous chemotherapy need IAC or plaque radiotherapy additionally for globe control. How often do we need intravitreous chemotherapy? I think you're going to be surprised when you see this. 10% or less. We don't need it that often. When we're giving systemic chemotherapy, that chemotherapy gets into the vitreous, and our need for intravitreal chemotherapy is low, 9 to 10% or less. Now, what about IAC for retinoblastoma, used mostly for unilateral cases? Well, our program started in 2008, so we now have 16 years follow-up. We have 2 full-time neurosurgeons who perform the catheterization. They never pass the case, they do their own work. And this is why we have such good results. They catheterize up to the ophthalmic artery ostium without entering, inject the chemotherapy into the eye, and you can see before and after. No consolidation. This patient only received 2 doses of melphalan with good control. Here's another one with group D exophytic retinoblastoma with subretinal fluid before and after, 3 doses of melphalan, no consolidation. Do we ever consolidate after IAC? And the answer is never. We never consolidate. Why not? You don't need to. And it produces retinal necrosis at the site that you treat, and you're going to get visual field defects. So in answer to all these protests, chemotherapy does not work for retinoblastoma. Chemotherapy will lead to tumor recurrence and possibly patient death. Not right. Those protests were wrong. And thanks to Dr. Judith Kingston, she passed away, unfortunately, in 2016. She never sought the limelight nor recognition for her work. The only reward that she wanted was the recovery of the children she treated. She teamed up with John Hungerford. Their joint collaboration marked a revolution in the way retinoblastoma was perceived and now treated. Her pioneering work transformed the lives of so many retinoblastoma babies and their families. So in June 2015, at the International Society of Ocular Oncology, just 7 months before she died, I publicly thanked Judy Kingston for her recognition of chemotherapy for retinoblastoma, and I told her story. She received a standing ovation at that meeting. May she never be forgotten for her contributions to retinoblastoma. Courage, hope, desire, and a good idea was the perfect combination. So in conclusion, management of retinoblastoma with primary intravenous chemotherapy at 20 years is excellent. A, B, and C have, groups A, B, and C have 90% control with globe salvage or better. This is thanks to the pioneering work of Kingston, Galley, Murphy, and Shields. And then IAC for retinoblastoma, thanks to Kaneko, Abramson, Hagestinilau from Italy, and Shields. Primary IAC at 5-year follow-up provides 100% control with globe salvage for groups B and C in our hands, almost 90% control for group D, and about over 50% control for group E, but you may need to use additional therapies of intravitreous chemotherapy in those cases. So in answer to this adverse reaction, chemotherapy does not work for retinoblastoma, I have to say that's wrong. Chemotherapy for retinoblastoma really works, and all of us have seen this in action. Thank you.
Carol, thank you very much for the insights and the huge amount of expertise. Can I add something? Does chemotherapy work alone for retinoblastoma? Because, you know, in Africa, we do have chemotherapy, but we do not have real expert ophthalmic oncologist. So are you okaying using chemotherapy alone for retinoblastoma without consolidation therapy?
Thank you, Dr. Othmani. Can you hear me?
Yes, perfectly.
Good. Yeah. So basically, we deliver chemotherapy either by intravenous or intra-arterial routes. And when we give it by the intra-arterial route, we don't consolidate. It is more powerful, and the chemotherapy alone can cure the retinoblastoma, and you might only need 3 or 4 cycles. So intra-arterial chemotherapy, in answer to your question, we don't consolidate. With intravenous chemotherapy, it's a lower dose, it goes systemically, and we think we need to consolidate. But there is some new discussion among ocular oncologists that maybe we don't need to consolidate with intravenous chemotherapy. And if we see recurrence, we switch to intra-arterial chemotherapy, which is more powerful, but can only be given to one eye at a time. So in answer to your question, in the past, we used to consolidate everything. And by consolidation, I mean, we would, after the chemotherapy, laser the tumor or cryotherapy the tumor. But now there's more and more thinking that maybe we don't need to be doing this as much. What is your opinion, Dr. Othmani? I know you have a lot of experience. What is your opinion on that?
Well, I used the intra-arterial chemotherapy back in 2009 after the publication, of Dave Abramson, and after seeing your work as well. In initial experience, we used only melphalan, 5 to 7 milligram, but there were recurrences. There were seed recurrences, and the only cases where, one of few cases where I haven't seen any recurrences, there was so much damage to the vascular supply of the eye that I would say that, this was the cause of not seeing recurrences. The experience wasn't so great for me in Egypt in 18 eyes. Like was like 13 years ago. But I know we are reconsidering now for special indication and cases for that. My thoughts are towards the episcleral chemotherapy, and I think once we have something available to be put onto the sclera of an eye or the other or 2 eyes to deliver on a constant base chemotherapy for 3 months or 6 months, maybe this will induce the damage enough to the cells not to grow back. And maybe I would definitely look into advanced disease when you have stage D or E, if it regresses and with persistent chemotherapy over time, maybe I can accept at the time that maybe consolidation is not of use.
That's good. So you're talking about the chemotherapy plaque. Yes, that can work in controlling extensive seeds. The only problem with that is it can cause scleral thinning, and there have been a couple of cases of scleral necrosis. The newest use of chemotherapy is high-dose topotecan injection using topotecan 100 micrograms in 0.18 cc. That can control subretinal seeds. So there's a lot going on in this field, and we are making headway.
Excellent. Thank you again, and we're looking forward to getting you in more meetings, Carol. I appreciate your time, and all the best to Jerry and the kids. All the best and all the good wishes.
Okay, thank you very much. Good luck to all of you.
Bye-bye.